sessile striatal lesion, and now at our Center for Endoscopic Resection.
We're going to remove open, if you could, Ryan, the snare. You can see that this lesion is probably about 14 millimeters in diameter. And we hear a lot about removing lesions on block. I will say that that's obviously a very important concept when there's a risk of cancer. I personally think it's way overblown when there's no risk of cancer. And the risk that this lesion has cancer in it is virtually zero. So I'm not going to take that approach. My approach is generally, we're using a 10 millimeter snare, and we're going to place the snare so that we get a wide margin. We'll reopen, and again, we're going to place the snare so that we overlap the submucosal defect, close, and the normal tissue cut. And if we sort of get a little bit stuck, we can just pull that through. Now, that's a submucosal cord right there. And in general, I'd like to not get, don't take that, we're not quite done, right? I'd like to not get those, but you know, if we get them, not really a big deal. So part of the reason that we're choosing cold resection here is that the histology of these lesions is definitely serrated, and we've got a pretty good body of observational literature showing that cold resection is very effective. The other thing I would say that you'd be thinking, you should be thinking if you're a general endoscopist, I think it all the time, is when I get a story like this, is does this patient have serrated polyposis? Because we were referred this patient with 3 lesions that had been measured at over 1 centimeter that were serrated. So using the new criteria, all we need is 2 lesions 5 millimeters or larger proximal to the rectum, and we've got type 1 serrated polyposis. You know, it's telling you what you already know, by this inspection. Now I'm going to start snaring, and a few things, again, I've got a nice margin. And the second thing is you can see the tissue coming up through the snare. And I want that because that tells me that I'm actually going to get some tissue and get into the submucosal plane. And
Doug,
go ahead.
sorry,
Yeah.
One question. This is Uzma. The audience wants to know what you're injecting with.
This is Everlift, which is a cellulose based product. And now here again, Uzma, I'm placing this snare, so I've got margin in the submucosal defect and margin of normal mucosa, and I'm not getting so crazy close. A couple of different mistakes that are made close. One of them is biopsying serrated lesions, as I've discussed. I sometimes see people say well, all I did was biopsy the edge of the lesion. So, you know, that didn't cause too much trouble. But in fact, the edge is always something, you know, we're cutting through.